No, we're
when's the
not-
first
we're
dry
not
run
to that.
scheduled? Are we even close to that?
We're not to that point, probably not until.
It's November, yeah.
November?
November.
We will start registering patients duplicate of our tech time system for the financial side. We'll put in some dummy charges and some dummy payments, patients, and start testing those through to see if the claims will come out, clean claims and that sort of thing, and that will probably start happening next week. And we will run through the mock training, which is the end of November.
Yeah,
So,
and that's wise, the
So
financial
running them
part of it
side by
is-
side is probably pretty wise to
Yeah.
do that, making sure the system
Okay.
works.
Anything else about the EHR? Okay. How about, let's get a mammography update, project update.
Our open house is October 4th, and everybody here in the room is invited. We have the bus going out to Alberton to bring in people, then also to St. Regis to bring in people. And you can call Monty Turner and make sure, if you want to do that, you contact him and get picked up and find out where to be picked up. October is Breast Cancer Month, Awareness Month, and we'll have an open house here from 11 till 1. And you'll all be able to see the equipment and what's happened there. We are just finished a little bit of flooring there. We painted some rooms and so forth. We think it'll be outstanding. And the equipment that was produced in France is supposed to have been here yesterday or today. It's held up in customs. It'll get here now Friday unless we can move it up a day. They take 4 days to come from Milwaukee. It has left
Are you
Milwaukee.
sure we want it if it's from France?
It's
You know how
it
they
has
love us.
GE's name on it. It has, and I was surprised it was produced in France, but that's where they produce this piece of
It's a
equipment.
good piece, yeah.
And it's they produce a lot of them. They sell 4 or 5 a month, and they're expensive, $275,000 a piece. We have the Helmsley grant that is taking care of that. And most of the construction project, not all of it, we have our maintenance crew are doing a lot with that. And we think it'll be a very pleasant room, and providing that service again. We've had it up till now, but it's digital mammography now. It goes faster, and it's a much better, it's innovative procedure. And the old equipment was 15 years old and was no longer up
Standard
to
of
date.
care.
You know, and so in fact, we'll be beyond the standard of care for a year or two, and then others will, it just moves as it moves. But it's not only screening, it's also diagnostic. We were able to upgrade the equipment enough so it's diagnostic, and the radiologists who read the mammograms can tell you if there's a problem or not. Not just, this is a screen, go get another test. They can go beyond that now. So we added that feature. It wasn't initially there, but we were able to add it and get even a better price. So
So what time is that on the 4th?
11 o'clock to 1 o'clock on the 4th in the new mammography suite.
So
And we
then,
will,
when does it start taking its first pictures?
I think the 6th or the 7th, there's a little
So
bit
that
of
week?
training. Later that week, early the next week. I think that's a Wednesday or Thursday. No, that's a Friday.
Friday.
So the next week we'll start using it.
Okay.
Because it's coming late, and we need to make sure that our techs are up to date in their training, and that happens because of a scheduling problem the following Monday, Tuesday, I believe.
Okay. Thank you, John. Okay, let's move on to our finance report. Good. Review of financial metrics. This will be good.
Okay, do you want to go over the financials a little bit first, or when do you want to do that?
Well, if we want to go over that and then over the
Build that
metrics.
again.
Huh? Yeah, that's why, my question is, how much do you want me to go over this? Since we went through it.
Well, the committee had a recommendation to approve the financials for August. So we can do that. I don't know if we need to go into the specifics of this, because the financial metrics had more to do with
Okay.
the ratios and things that we had requested.
All right,
So
okay.
I think everyone probably had a chance. We got these, by the way, that was really nice to get these ahead of time.
Yep.
So that, I mean, we could review them and take a good look at it.
Yep, yeah, I appreciate it.
Going to pass those out?
Isn't that part of it?
Are these in the budget? Are these in the packet
No,
now?
no, no, I just made a separate page.
I keep saying the
I
same
couldn't,
thing.
I can't believe it, because it's sometimes hard to get them by this.
Well, you have this.
And this is the same as this one.
Yeah, yeah, and I'm sure that we have this.
I need one for minutes, yeah, thank you.
Yep.
Yeah, we
Yeah,
got
so
those, I'm
done.
not sure.
Yeah.
Yeah.
Okay, you do
Okay,
have.
so what Amy's asked me to do is to go through the financial ratios that are in this Kaw Hospital Financial Manual. Did everybody get one of these?
It's in everyone's training, it was in their
Okay.
training binders.
Yep,
All right,
I think I've been hard.
so these.
Which
these
I don't
are-
know how we even survived without that.
It's a good thing to have.
There's so many of these things how did I not?
So now we
notice
can
it?
test you on all the acronyms?
Okay, how's the flex monitoring team going for you? You in contact with them?
Yes, actually, I was.
And I was looking at your comparisons here with the Kaw Financial Indicating Report 2010 data. Kudos for updating that, because all the comparisons we had were like 8 years old and they were just
Right.
completely irrelevant. So it's nice to have
Well,
some.
unfortunately, all
closer-
of, the ones that are grayed out here are the old ones. They're not, I couldn't find updated ones for those just yet. Because the, what it refers to in here, the flex monitoring program, they only posted the ones that I changed. So I'm not sure where to get the other ones. Well, I know places, but it costs money. So I numbered along the side here, 1 through 10, so that we can just, number 1 is right about in the middle of the page, net days in accounts receivable, and there's, number 1 and 2 are very closely related, gross days in accounts receivable down at the bottom of the page. And those are, of course, what that is it measures how long it takes for us to collect payments, and how it's measured is our gross or net revenue per day is divided by the amount, or by the amount accounts receivable. And so that's how you come up with the ratio. Our net days right now are high, whereas the state of Montana is like at 57 and we're at 98. And the same with the gross days, are just a little bit higher. Those two should be very close together as far as their ratios.
What would be
So-
the difference? I didn't quite
Well,
understand that.
The difference
Where it said that
is
they're-
in the net days, it subtracts things like the contractual allowance for Medicare, Medicaid, insurance companies, your bad debt expense, anything that discounts that. And it's also, and then the net accounts receivable is just that, less is your gross accounts minus your allowances for those things.
So when, in the manual, when it says if your gross days are higher than net days, the organization's allowances may require further analysis. Is that really true?
Right,
If
because then, because if
it's
you're.
things you already know.
Yeah, what it's saying is if you're not matched on that level, you probably better, your allowances, you should take a look at how much your allowances are, because a lot of your Medicare and Medicaid, all we can do is estimate those all the time.
Mm-hmm.
So you have to estimate those and make sure that they're reasonable. Number 3, days cash on hand. Right now, we show 23 days, and that's mostly because we haven't spent all the Helmsley grant money yet. That's what that's about. And that is just the number of days cash that you can have that you have on hand that'll cover that many days of expenses. If your cash flow was totally cut off, that's how many days of cash you could cover. And so that's a critical number, and it should be much higher than it is.
What's the optimum?
You have optimum infinity.
True.
As in Apple, they have.
Let's be realistic then.
Yeah, that-
Apple has 90 some odd billion dollars in cash sitting in the bank right now. They are the most cash-rich company in the world.
They're not a hospital, let alone.
That's right.
But we've seen them, a few years ago, I remember seeing, I mean, we were like yelling hallelujah, they were up around 70, I
Yeah.
think was, like, we were like, oh, yes,
Yep, that'd be
So-
nice.
just
Well,
as a
and-
reference.
Well, I'm looking across the chart, we're lower this year than, the previous fiscal year.
Okay.
National Critical Access Hospitals has it at 68, and Montana hospitals are at 99.
Right.
So.
I don't know if
we're-
I believe that.
We're
Yeah, I
way
was-
down there.
Well, I know of a hospital that's actually not in Montana, but they're similar size to us, and they have $6 million in cash reserves. Can we borrow? I haven't asked that yet. His board probably wouldn't approve of that. I do want to mention, though, that I have not updated that prior fiscal year column in the middle there. That's one of the things that I need to get caught up on. I didn't realize that until I was looking at this. I'm like, what? What
What's
the heck is
different?
that?
Is this like,
Is that 2012 or rather than?
yeah,
Yeah,
is
it's
that
probably 2012.
previous year?
That's
Okay.
2012, yeah.
Okay.
And then total margin, that's where you'd like to, that's your, what they call change in net assets, which is basically your net income divided by total revenue. And right now, our total margin for year-to-date is negative 0.93, and all hospitals 1.39%.
I've never
Yeah.
seen that positive.
It has been positive.
It has? See, I've never
It's just-
seen.
It hasn't been that way, it has been positive for a couple of years. 'Cause that's one that you want it to be positive. And your operating margin, that's probably the one you've never seen positive.
Okay.
The operating margin is the same thing, except it's before donations
Mhm.
and the tax levy. So any grant income or anything like that is not included in the operating margin. That's just your total, like, net patient revenue.
That's a more
versus-
realistic number.
Versus your expenses. If you could,
Yeah.
in our situation, if we just got that to be right at zero, we'd be in good shape. Not great shape, but good shape. And then that's, let's see, so then we move on to debt service coverage ratio. Number 6, we're at 1.88, all Montana hospitals at 2.87, so we're low. You want that to be higher. And of course, that's not surprising to us that would be lower with our financials. That's the ability for us to pay obligations related to long-term debt. So when you go to borrow money, that's what, a lot of times what they'll look at. Number 7, salaries to net patient revenues. Ours is gonna show high because we have a nursing home right within our hospital. And so you have a lot of employees in the nursing home versus other areas. And actually, when the clinic was on there, that was even higher yet. 8, the payer mix percentage, that one's not on here, and I didn't calculate that one, but our inpatient payer mix for Medicare is probably usually runs around 80%. And what they're saying in here is you want that to be lower, because with Medicare, when they pay you, it's all designed so that they pay you at 101% of cost. but your cost is what they define it as. So if you have expenses like marketing, that's not an allowable cost under Medicare. If you have physician recruitment costs, that's not an allowable cost under Medicare, so, you know, if you have other payers, that's better, as long as they're paying. The good thing about Medicare is they usually pay.
So that's inpatient, it's 80% Medicare. What is, the rest of it's just private?
Hopefully insurance,
Well, that's what I meant,
And-
private insurance.
yeah, and self-pay.
Is Medicaid part of that?
Yes.
What kind of percentage are we looking at Medicaid?
Medicaid on inpatients usually fairly low, it's probably, gosh.
Less than
even like-
10%, isn't it?
Yeah, way less than 10%.
Okay.
I mean, I've seen years where I don't think we've even, where we probably had, you know, like 16 Medicaid days one year.
Mm. What about our outpatient?
Overall, we're probably about 50% Medicare and Medicaid. Let's see. 9, average age of plant. This is the one place where we look good on there. And the reason that is first of all, it's calculated using accumulated depreciation versus your depreciation expense. So the newer your equipment and everything, the more your depreciation expense is gonna be. And of course, when all our buildings were built and everything, that was built, you know, you only have, what, $3 million in buildings. But recently, we put in the biomass, we've gotten the CT scan, we're getting the mammo unit, our lab equipment's been updated. So as far as equipment-wise and everything, we look pretty good. We've got really good stuff. And so
Does like EHR come into that?
it will, yes.
Okay.
And
So it takes all, is it just all equipment, all capital
Right.
equipment?
And so so we actually don't look that old here, just don't walk outside.
I say we don't look that old because it's so old that it's low numbers. The old stuff is in there
That's
with
kind of
low
what I'm
numbers.
saying, yeah.
Yeah, yeah.
We're,
So it doesn't take that much to make
We're
it look
antique.
new.
Yeah.
it's an antique outside.
But it's,
So the value's starting to go back up.
Yeah, that's right.
so, like I said, I mean, as far as our equipment, we are.
It's a
we are
historical
new.
building.
Right.
Is that how it works?
And the last one.
Historical landmark?
I don't want to say that, I want to update that.
I know, I'm just kidding.
I want to fix the ER doors.
Yes, we
That's
know
me.
you do. We know.
It's working. Long-term debt to capitalization measures the percentage of net assets or equity that is debt. And so the higher that is, the worse off you are. You see all Montana hospitals 21 and the nationwide is 26. And we're at 34%, so that's not a good number. I mean, we're not way off the page, but it's not a good number. And those are the kinds of things that, you know, that are looked at when you go in to get into more debt.
And now that we're starting to look at these, the next step from looking at these is for management to start coming up with plans to improve them.
Yes, that's right.
And there's 2 ways of doing that. That's one which is the best one, is to increase volumes and revenues. And second is to decrease expenses.
And that's what our weekend planning was part of too.
Yep, that's right.
Yeah.
I mean,
But we've got to be planning on making those numbers better and focusing on making those numbers better and continuing to pay attention to
Yeah.
them.
that's why these are good. These are the kind of the end game, but as you're playing the game, you got the volumes are the ones that are going to make the difference to
Right.
get to these.
Yep.
If you can have great volumes for a year, then these will improve.
Right.
but it's gonna take a little bit to get there. Alright. And then for the budget part, John had something that, you wanna go over your budget?
Oh, yeah.
Changes?
We need to submit a new budget to you probably in October, because we've got some budget changes coming up. We will have a surgeon here, probably starting in late October or November. We have Ideal Protein that affects the budget and both revenues and expenses, and we need to add that. And there's one other thing. Those are the two large items. Oh, we've had some changes in how those who are paid through our budget, and so we need to adjust the budget for those items that we talked about in the Finance Committee, mostly through changes in personnel. We're down about $129,000 for the year in expenses, and most of those are people expenses, and we hope to keep that going in that direction. Going down is tough, though, because we've got to staff enough to take care of the nursing floor, the patients, and then the ERs that come in. And we can't beat an ER here by anticipating, say, okay, we need another nurse, have them come. It doesn't happen that way. So we have to have enough flexibility to have a nurse assigned to the ER. We do bring in a doctor, but they're sleeping or they're there next door, either way. So going down with our expenses, there's a floor there that we can't go beyond, and we're getting pretty close right now. But if we go up in our volumes, we won't need to staff up much except some in nursing, because that's a direct relationship there. We have the staff in most of the other departments to go up, I think 15, 20, even to 50% in many of our volumes, and not staff up for it. We'd have to do something in nursing and look at it here and there. And Kirsten does a good job because she has a number of employees, CNAs and others, who are part-time, and she'll expand their time as they go up and be able to cover that. Lots of people in the rest of the hospital don't have that. She has about half the employees in the hospital, though, and does a good job managing her people. So we will be submitting that, we'll be working on that in October and get that to you hopefully at the October board meeting. I think we can make that,
Okay.
because there's just adjustments to it.
We still need to do, well, when we get that, we still need to present our budget to the county commissioners.
Yes, it would go then to the county. Once you approve it, it'll be, go into the county as an amended budget, that's correct.
Okay.
Could I ask a question? George's salary, is that part of the clinic's problem?
George Bailey?
Yeah.
No.
No.
So how much did you gain by losing him?
We gained 30%. He worked in the hospital and for the grant. But so 30% of what he was being paid was part of that.
So, okay. Are there any other questions about that? We do need to approve our financials. That came out of committee for that recommendation.
And I'll make that motion.
I'd second.
Okay, thank you. All in favor of approving our August financials?
Aye.
Aye.
Okay. Quality report. Kirsten?
Oh, Mitzi, the quality report. It's not on the agenda every month, it's just quarterly.
Oh, okay, well then, let's,
So,
it
fix
probably
that,
shouldn't
but
be-
John,
okay. How about we have an update from our customer satisfaction committee?
We've been meeting weekly. They've been excellent meetings. Our purpose was initially to prepare a customer satisfaction survey, put all of those that were being prepared by the hospital and sent out into one. And there is a survey that is used nationally now. It's called HCAHPS. It's HCAHPS. And we're looking at using that The grant is working with all 20 hospitals that they work with, the CAW hospitals in Montana that they work with, and they're talking about helping to fund going to HCAPS. But because we don't have as many acute care patients as the rest of them do, we want to expand out to do a lot of our outpatients. And so we're working that through right now to see what it'll cost to buy a survey, and then they slice it and dice it because they have it computerized in ways that it would take us a long time to do. But we're.
Tell me what's HCAPS again?
HCAPS is a national survey that is principally to Medicare and Medicaid patients, I believe. And they survey a percentage of those patients that go out of every hospital. They send out the survey, and it's principally done by large companies that are contracted through the hospitals, and they provide this HCAPS survey that's been developed by the federal government, and there's, I think, 39
So we want to
questions.
access that information, is that what we're?
Well,
Do
no,
they-
we would do the survey and then get it back. And it would probably be summarized, our information with all the hospitals across the country that are CAW hospitals, so you get a feel for what all those patients are doing. But because we don't have that many inpatients, it's principally an inpatient survey. We had 6 inpatients last month, and if we get 15 in a month, we're doing well. So it's not a meaningful survey with that few patients just for us. So I want to add, and the committee wants to add outpatients to that, so it can be more meaningful to us and we can measure more things. And that'd be just for us.